you, Mr. Chairman. I thank all of you as well. I guess I'm going to say I'm a bit confused because Secretary Council said that on April 8th you were certified interoperable. Well, we're hearing conversations that, so, and then Ms. Melvin said that an interoperability system is still years away. I think that was part of your statement. So help me with those. That seems like a direct conflict there. Are we talking about the same thing, or how do I square those two statements?
Okay, I'm going to try to simplify this and talk in normal ease versus technical ease.
Thank you. I'm very grateful for that.
So let me start with the concept of a system. Okay, the system is, if we want to think about it themselves, the inner workings, the system, what all works together. The data is the artifact coming out of the system, going into the system, and it actually can sit separately from the system. Data, system. I think Ms. Melvin was referring to an engaged system being on the same system platform, and therefore assuming interoperability would be driven by being on the same system platform.
So what is the objection to having a single system, as she mentioned?
Okay. The reality of a single system, in order for you to ensure that you're going to drive the same level of data out of that system, is that you would have to sit on the same instance time of that system. Not just the same name system, but the same capabilities, no difference in that system.
And why can't we do that?
The reality is there is no system that can support both DOD and the VA at the same time. It will not scale. It will
Well,
not.
we've got Amazon that can scale. I mean,
At the same time, there is no system that will support all the things you have to do the clinical management and the clinical operations at the same time.
Ms. Melvin, do you have any comment on that?
I would start by saying that we are not trying to define what an interoperable system is for VA. We have been looking at this over the years, and as has been discussed, the question has been, and what they've been working toward, as we understand it, is a fully interoperable capability. When we talk about fully interoperable, we're asking them to define what they mean by the data exchange, what has to be exchanged, what capabilities and to what extent. Those are questions that haven't been answered yet in terms of, when you talk about full interoperability, exactly what is it? What kind of performance measures and metrics would you put in place to know that you've gotten a full capability when you get there? Whether it's...
Excuse me. So for the discussion on whether your x-rays and tests and everything are a part of that, are you including that as part of defining what interoperability is?
Absolutely. It's understanding all of the medical information, all of the systems that that information would have to come through, and what are they doing in the way of the exchange capability. How will they know when all of the information that they need to ensure that a patient's health care is fully taken care of? How will they know when they've gotten to that point, or they have a system that gets to that point? We did say that, or we did encourage one system as the way, and they, in fact, had stated that one system was, in fact, the way to go when they went with the integrated electronic health record approach in 2011.
From the panel that they are coming up with two different systems, and the only government bureaucracy that can mandate one system. My preferred outcome would be, since Laverne owns about 20 million patients, and Dr. Waltman owns about 2 million patients, that it's only this committee that could mandate a VA lead to make sure we have one seamless system.
So let me just, in my final 2 minutes, ask you, Dr. Thompson, because you mentioned private sources. So we've just created the choice card. We now have our veterans going out to private providers because of the issue of getting an appointment, timely, distance, all the things that we know exist. And this has been going on in the VA system for a while, but we've expanded it by the choice card. how does this going to be interoperable with private providers? You have no guarantee. I'll just give you an example. My state of, say, West Virginia, we have a lot of issues with broadband deployment. We just started a broadband caucus yesterday I did to meet this issue. What do you anticipate in this area? And that's my final question.
I can speak to DOD, and I would defer to Ms. Council to speak for the VA. The DOD participates in what is called the eHealth Exchange, which is a public-private partnership of both government, including DOD providers and private sector providers, providing data through health information exchange organizations.
So would you say that your private providers are on the same e-records as the DOD?
For those providers that are participants in eHealth Exchange, they do have access through to the DOD
So there
data.
could be providers that were not on the eHealth Exchange?
Providers who are not presently on eHealth Exchange do not have access to that data.
So you could have an active military person go to a private physician and they could not be on this eHealth Exchange, and you wouldn't have that data back at the DOD. Am I hearing that correctly?
That's correct presently. The DOD is moving aggressively to increase the number of health information exchanges and providers that are participants.
So this layers on a whole nother issue. And quickly,
We do participate in HIE at the VA with over 1,500 of those in the U.S. And what that is standardized data structure, and that's when I was getting to the data. At the end of the day, that's what you've got to have be interoperable, and you need a standard across that. Within the U.S. today, the standard that's being built is called Health Information Exchange, or HIE, and we participate in those HIEs as a way to engage that information today.
so veterans using the choice card could go to a physician that aren't in the Health Information Exchange, and therefore their records are not interoperable with you?
What we do at the VA is if they go to a doctor that's outside of our process, we will reach out to that doctor and get that information one way or the other. If we can't get it electronically, we will get it. So one of the things about interoperability, and I just think it's important to remember, it has a continuum. One part of the continuum is non-electronic, which is how we've moved things before. I hate to say it, but it's paper. The other one is called semantic, which is data flowing and data moving and talking to each other. We're on that continuum constantly, and healthcare has been on that continuum constantly, moving to that standard called HIE.
Thank you.